Welcome to all of those joining us. I'm Jessie Bengoa, and today we're here to walk through an unfortunately not so rare diagnosis of EPM, or Equine Protozoal Myeloencephalitis in horses. It rolls right off the tongue. EPM is the most common neurological condition in the horse, at least here in this country. And it's caused by two primary protozoan parasites. We've got Sarcocystis neurona, and not quite as common, Neospora husei. Again, rolls right off the tongue. Both being introduced through infected sporocytes in possum feces ingested by horses by just being horses, grazing off the ground and nibbling on anything that's come into contact with these parasites. And to take us through what EPM looks like as a diagnosis and the latest on how this condition is being handled in clinical practice, I'm joined by two of the very best. Let me first introduce Dr. Bryan Waldridge. Hello, Dr. Waldridge. Thanks for joining us.
Oh, you're welcome. Great to be here.
Dr. Waldridge has long experience teaching in academia at Tuskegee and Auburn universities, and also in clinical practice at Rood and Riddle Equine Hospital and Park Equine Hospital, both in Lexington, Kentucky. And now he's at Mississippi State. And his special interests include internal medicine and clinical pathology. And together with Dr. Waldridge, we're joined as well by Dr. Rodney Belgrave. Hello, Dr. Belgrave.
Hello.
Hello. Dr. Belgrave is president of Mid-Atlantic Equine Medical Center in New Jersey. And he's authored numerous papers published in peer-reviewed journals, and he's a frequent presenter, industry contributor, and he's dedicated so much of his time and talents to the betterment of veterinary medicine. And these are two good friends of ours that I'm happy to be here with. So let's better understand EPM and how you're tackling this in practice for the most successful outcomes. So Dr. Waldridge, let's jump right in. I'm going to point this first question toward you. Give us an idea, if you would, of the pathophysiology of EPM and sort of what's happening in the body, and particularly the nervous system, when a horse ingests one of these two parasites and begins to develop this condition.
When that parasite gets into the horse, it disseminates through the body. It appears that once it gets into the neurologic system, it's sort of isolated from the rest of the immune system, and so it's able to just find a place to go. You know, the parasite's lost essentially in the horse. You know, it just only completes its life cycle in the possums, as far as we know. So once it gets into the neurologic system, it sets up mainly in the spinal cord, but it can go to the brain and the brain stem, maybe a little more likely the brain. When it does that, it damages those neurons, the main cells that work the neurologic system, causes inflammation, swelling, and from that we see wherever those neurons are damaged is where they are responsible for in the body is where we see the clinical signs. So essentially, it just sets up house, damages anywhere in the neurologic system, but especially spinal cord, and from there we see the clinical signs.
Excellent. Thank you for that. And correct me if I'm wrong, but I mean, it's upwards of 50% or over of horses that will actually test for these antibodies, but fewer than 1% of cases that become clinical. Am I getting that right?
Oh, that's right. And it's probably higher than even the 50% in some areas of the country. If you lay the map of the United States where the opossum lives over top of where EPM serology or positive serology, where the antibody results, they line up very well, and that if there's possums, then the horses are positive, and the older the horse is, the more likely it is to have a positive titer to EPM. So, you know, it's here in the South, I'm surprised when I get a negative titer back, meaning that the horse hasn't been exposed or unlikely to be exposed.
Yeah, definitely. Dr. Belgrave, as a follow-up to that, I want to turn to you to walk us through the clinical signs of this condition. And what are the differences you're seeing with spinal involvement versus brainstem involvement? And, you have a patient in front of you. What do you see that has you suspecting EPM?
Well, the tough thing about EPM is, just falling back on what Dr. Waldridge said, the signs are totally dictated by where the organism migrates once it gets into the central nervous system. So We can see horses that present with just spinal ataxia, which is really difficult to distinguish from, say, a compressive myelopathy or wobblers. So those cases are a little tougher. And we can see horses that will, if there's brainstem involvement, we'll see horses that have cranial nerve signs. I had one about 2 months ago, difficulty swallowing, was dysphagic, and she's recovered with treatment. So it's a very unpredictable disease, and for that reason, any horse that presents to us with neurologic involvement, neurologic signs, you always have to consider EPM as a possible cause, because of how varied the clinical signs are. For me in practice, I don't feel like, 15 to 20 years ago, we tended to see a lot of really per acute cases of EPM where they would present really acutely neurologic and sometimes recumbent, or sometimes they might present with atrophy to suggest muscle atrophy, to suggest that there was some peripheral nerve involvement. I'd say those cases are in the minority now. And the majority of cases, just present as your garden variety spinal ataxia, which is really hard to distinguish from, a lot of other neurologic conditions.
So interesting. Well, thank you for that. And Dr. Waldridge, I'll point this one back to you. There's a difference in commonality and in symptoms, right, between the two different parasites that are at play here. So the Neospora husei, correct, while much less common, it can actually be passed from a broodmare to her offspring, right? What are the differences in what you're seeing with the two parasites?
I think there are some studies that have shown there's some horizontal vertical transmission with the Neospora husei. Clinically they're going to look the same, because wherever that parasite goes in the nervous system, it's going to cause the same inflammation. And while the Sarcocystis neurona is far and above the most likely organism, essentially they're indistinguishable other than by the test. And so that's where the treatments would still be the same. For diagnosis, want to send those spinal fluid samples and blood samples to a lab that can test for both organisms.
Excellent. Okay. And, to dig a little deeper into that with the diagnostics, is that where it stops with diagnostics? Obviously, there isn't a definitive test that can be run on a live horse to say, yes, 100% you're dealing with a case of EPM. But Dr. Belgrave, what are you using in your diagnostic tool bag to land on an EPM diagnosis?
I would say we have the ability to definitively diagnose, right? And there are a few labs across the country that offer testing that I think is reliable. I don't know if you want to get into those, but but really what it comes down to is, to definitively diagnose, you need to do a spinal tap and test the spinal fluid, and not just the spinal fluid. What we look for the ratios of antibodies in the spinal fluid to the serum, and that's been shown to be more reliable than the individual titers in either the serum or CSF. So the ratios are what are most valuable, and I found testing hugely reliable in getting to a diagnosis.
Sure. Okay. Excellent. So we have an EPM diagnosis. Dr. Waldridge, what are your immediate steps from a treatment perspective? So we've got various drugs, we've got NSAIDs, corticosteroids. And in our world of advanced nutrition, we've got things like vitamin E for neurologic support, or healthy weight oil for the straight omega-3s, or platinum GI that we go to for really kind of that whole horse approach and support of the gut and immune system. So what are you reaching for?
Well, it's a lot of that. You just had to have a bit of a conversation with the owner and find out about expense. And if we use a Panagereal, a little bit more expensive over the short term, that we can treat the horse for 28 days. If we go with the sulfapyrimethamine, kind of the old treatment, then we have to commit to treating that horse for at least 3 months. So really the cost of that kind of narrows a bit. So I go through that with an owner, that how much is their short attention span there, that they want to do a shorter treatment. Because I think if you do with the sulfas, again, you got to commit to at least 3 months if we're going to do that. The other thing I do is I do like to add in some vitamin E into those horses. And I think there's pretty good evidence vitamin E is beneficial to the nervous system to help get the best healing we can get, because we're limited how much healing we can get. So if we can support it, I think that helps, has some anti-inflammatory effects. And if we use the nice natural vitamin E's, then there's good evidence we get that in the spinal cord, or in the spinal fluid, and the horse absorbs that well. And then I'll usually put the horse on a few days worth of a corticosteroid, because you can really have treatment crisis where you kill the organisms. When they're dead, they're more inflammatory than when they're alive, and potentially that horse can look a bit worse as those organisms begin to die. So I usually go with either of those two treatments, and regardless, they're going to be on some corticosteroids and some vitamin E with a loading dose, and then just keep them on a maintenance dose after that.
Excellent. How about you, Dr. Belgrave?
Yeah, just to echo what Dr. Waldridge said, we have our cidal drugs that can, where the course of treatment is a lot shorter. Yes, they're more expensive upfront, but when you're dealing with your pyrimethamine sulfur combinations, that require 3 to 4 months of treatment, it's sort of a wash in the end, I think. So, and at least historically, the risk of relapses, certainly been higher with, with the non-cidal type drugs. So, yeah, I usually give the clients an option of whether or not we use Panazeral or Diclazeril. One comes in a paste form, one comes in a pelleted form, and I both are very good drugs. And usually give the owner the choice of whether or not what's most convenient for them,
Okay.
And whether or not giving the paste or the feed through pellets. And but I would still say, on average, I would say that I even with the cidal drugs, I end up treating for 2 months.
Okay.
Just depending on the severity of the case and the clinical signs involved.
Right. What's the stress factor here? Can stress be the tipping point in this condition? How does stress come into play with these horses?
I think the best example of that was back in the early days of EPM, when we were trying to reproduce the disease experimentally, that they found that when they gave the horses large doses of steroids that you would expect to cause immunocompromise, still had difficulty to induce the disease experimentally. But when horses were shipped from Canada to Ohio State, that were shipped from Canada because they were negative to the organism, that they found with the stress of shipment, when the horses got there immediately and were tubed with the organisms, is a lot more reliable to induce disease. So I think stress, especially transport stress, is even a larger hit to the immune system than large doses of corticosteroids. So, stress is there, and also the dose of organisms, and perhaps strain differences in Sarcocytis neurona.
Yeah, like anything, stress is the enemy. Dr. Belgrave, as a follow-up there, how long are these horses, you talked about the horses requiring treatment for a couple months, 3 months or so. What are the outcomes and the relapse rates looking like with EPM?
With the treatments that are available on the market today, I feel like the survival rate, recovery rate is a lot better. If I had to put a number to it, horses that we see in our practice, I'd probably say around 80% or so. But again, that comes back to the fact that we don't see the really per acute cases that, we used to see 15, 20 years ago that would present in recumbency and just flat out, unable to stand. So, I can't remember the last time we had to hospitalize an EPM horse in a sling, but, 15, 20 years ago, it wasn't that uncommon to have to do that, to support them. So, so with the emergence of the drugs that are available to us in the market, and perhaps, maybe with more exposure to the organism, I'm not sure, but I'm not sure how to explain the fact that, at least in our area, we just don't see those really, really per acute cases as much as we used to.
Sure.
What about you, Dr. Waldridge?
No, I agree with you. I was talking to the students about that the other day. As you remember, kind of the old days when something came in, you treated it for herpes, you treated it for EPM, you gave them all the anti-inflammatories because it just seems like you couldn't tell as much when they came in, those really neurologic horses that seemed that they were acutely affected. And now it seems like you have a lot better, at least comfort with diagnosing EPM, oftentimes off the neurologic exam. So no, I agree with that. I think we're seeing them overall less sick, or at least less affected.
So why is that? Is it better immune support for these horses, better feeding, training, housing? What's the reason for that?
I think at least part of it's owner awareness. I think that everybody's done a good job educating owners about what's out there, because getting old enough, I can remember back when nobody knew what the definitive host of the organism was, and I can remember Dr. John Schumacher, who taught me, saying, well, because it was similar to toxoplasma, which everybody knows is cats, and back in the early days of EPM, he said, well, nobody really knows where this organism comes from, and maybe it's in cats. So the farm immediately went and got rid of all their cats. So you had to be careful back when we didn't know very much. So now I think people are just more cognizant and probably catch them quicker than they used to, and know that if they get them on treatment, they've got a better chance of getting their horse back.
Poor cats were the scapegoat. Okay. How about early intervention? Does that come into play with how successful these outcomes are? Or is it purely dependent on how severe the condition is when you see them?
I think there's a combination of both. Certainly, early intervention is the key to a successful outcome. And those initial signs, they may be very subtle, to the owner or rider, but I think early intervention therapeutic intervention is sort of the key to the success in a lot of these cases.
Interesting. And to sort of start to round us out, Dr. Waldridge, we know, like we said earlier, that upwards of 50%, or it sounds like even more, horses will test for these antibodies to the parasites, showing that they've been exposed. And every horse is susceptible. Obviously, it has a little bit of a geographic element that comes into play here. But is there a preventive approach? And we have talked about, owners becoming a little bit more aware But what can owners do to prevent against a clinical case of EPM as best that they can?
Well, we know that the opossum is the one that's spreading the organisms everywhere in the environment. So if we can keep feed in sealed containers where the possum family is not going to come in there at night and take up residence, and try to keep our feed cleaned up as best we can and sealed up. That's probably our most efficacious step. There was a vaccine years ago, but I think, getting back to your point there, that the vaccine couldn't be shown to be efficacious because, again, we know that we could almost assume a horse has a positive titer. I mean, it's been exposed, and very, very few of those horses get sick. So the vaccine was no better than natural exposure. So, coming from Kentucky, again, getting back to the cats, the other four-legged things that paid the price were the possums, and raccoons are an intermediate host of Sarcocistis neurona. So some farms are pretty aggressive at trying to rid their farm of those animals, but maybe a little bit of a tree hugger mentality that I have. But I kind of feel like maybe you want some possums on your farm so that there's some low level exposure. Pure opinion. I'd be interested to see what Dr. Belgrave thinks about this. But to me, having some possums around probably isn't the worst idea, especially in farms where you're raising thoroughbreds or sport horses that they're going to have a lot of stress in their life. And I'd rather have them have some exposure and some antibody to that organism instead of being, kind of a pathogen-free horse and getting out there and all of a sudden getting exposed. So, and there is some work showing that the pelletted formations of the EPM treatments could be strategically timed if I remember this correctly, at a lower dose, and had some preventive effects, some useful effects. So at least there's some evidence out there. If you had a farm with a high incidence, that you could do some preventive timed treatments, or at least preventive treatments, to try to reduce overall incidence. But that's very uncommonly done.
Yeah.
Interesting. How about you, Dr. Belgrave? Any thoughts on that?
Yeah. From a preventive standpoint, epidemiologically, trying to take out the intermediate host is probably the best bet. Whether it's them getting into the feed room, or, it's hard to prevent them from, getting on the pastures and eliminating that sort of exposure. But I think, doing your best to eliminate that intermediate carrier is probably your best bet. I do agree with Dr. Waldridge in that I wonder whether prolonged exposure, increased seropositivity to these organisms over the years has sort of dampened the severity of disease that we see, again, compared to 20 years ago. So that's possibly played a role in it. And so, maybe some degree of exposure is good for these horses. Obviously, for them to develop disease, there are a lot of things that have to happen, and it starts with, the load that they ingest, and it has to breach many barriers to get to the CNS. So, but yeah, perhaps exposure, or at least widespread exposure, is sort of mitigated the severity of the cases that we see overall.
Sure. It seems like it would make sense.
Yeah.
Where does, general well-being of the horse and general good care come in? Taking care of the immune system, taking care of the gut, all these things that are so important for horses that are under stress or travel, or, just in general, good ideas to do. I mean, is that something that can also help to possibly prevent
I think all of those things help because, you know, they all play a role somehow in the organism, you know, breaching the gastrointestinal tract lining and getting absorbed and eventually making it to the central nervous system. So anything that you can do to, you know, shore up those defenses to prevent the organism from, you know, disseminating through the nervous system, you know, is certainly helpful. So whether it's gastrointestinal support, neurologic support, yeah, absolutely.
It does seem like, you know, that elusive leaky gut, it seems like that's something you would absolutely want to prevent here. Yeah. Well, and in any case, right, and with people too. What is it that you would want, you know, both veterinarians treating EPM, you know, do you feel like there's a pretty good general understanding of it in order to obtain the most successful outcome? What would you want veterinarians treating EPM to know? And same question for horse owners, you know, in order to recognize those signs and get that intervention that their horses need.
You know, I think for me, it would be to realize EPM can kind of do what it wants depending on where it goes in the nervous system, but also it doesn't do everything. And you know, I've had I guess the most famous one here a few months ago. You know, a horse ended up having a fracture, came in for a suspicion of EPM, and it was actually impossible to convince the owner otherwise that the horse didn't have neurologic disease. It was lame. So, you know, I think the diagnosis is a lot more supported if we have signs of neurologic disease. So, you know, I think really looking at that horse, being careful with the signs, and wanting to get all of our data that we can to try and diagnose it as best we can before we go into treatment. So, you know, I think it's just having a real good exam, then, that we should probably have neurologic disease, or at least supports neurologic disease, you know, before we jump on EPM too quickly.
An open mind and 4 functioning limbs before you jump onto EPM too quickly. Okay. Dr. Belgrave, same question.
Yeah, you know, sometimes I think it's easy to attribute obscure issues to EPM. And so, yes, making sure that there's a, you know, a true neurologic component to what, you know, to what the horse is experiencing. And then, you know, I'm a firm believer in testing, as opposed to just, you know, shotgunning treatment. And, you know, I think if the owner's going to spend that much money, investing that much money in treating their horse, I think it's worth spending the money to test appropriately, you know, with spinal fluid and serum to determine if the horse is truly positive. Because if the horse isn't, then the money that, you know, you'll waste with treatment could be put towards trying to figure out the real issue behind the horse's, you know, clinical condition.
Sure. So like anything, a solid diagnosis is extremely important.
Yeah.
Well, excellent. And, you know, with that, I'll round us out here. And, you know, with EPM being a condition that so many horses and veterinarians have had to encounter, I'd really like to thank you both, Dr. Waldridge and Dr. Belgrave, for being here with me today to dive a little bit deeper into EPM and how it's being handled from a clinical perspective. So we certainly appreciate your perspective from myself and all of us at Platinum Performance. And I also want to thank all of those listening. So I hope you all join us again on the next one. And in the meantime, take care.